In this video, we're going to discuss a claim that I've seen made online by people who wish to defend the prosecution of Lucy Letby, that the comment made by Richard Taylor, who's on the screen now, Dr. Richard Taylor is a neonatologist, regarding the insertion of a needle is incorrect. This statement was also echoed essentially by the panel of neonatal experts when they released their preliminary report. The claim is that the needle that was inserted in the case of child O, that was erroneously inserted according to comments of both Dr. Richard Taylor and the panel, was in fact inserted correctly, and that it's perfectly acceptable or normal practice or even correct practice to insert this needle in either the lower right quadrant or lower left quadrant of the abdomen or the abdominal region of the anatomy. Now, I appreciate this sounds very complicated at this point in time, but I'm going to make it as simple as possible in this video. So, Richard Taylor, when commenting at a press conference in December, stated, and to summarise what happened, the nurse was again concerned that the abdomen was distended, and one of the doctors responded to this by placing a needle into the abdomen. So they directly aspirated the abdomen, and they chose to use a point, which in medical terms is called McBurney's point. This is a description of the point that is used for performing an appendicectomy. The baby did not need an appendicectomy. This is a newborn. An appendicectomy is completely irrelevant to it. If an aspirate was going to be attempted, it should have been done on the left side, but in fact the doctor used McBurney's point, which is on the right side. So that's all fairly clear. Essentially, this needle in this aspiration operation, an appendicectomy, has been inserted on the right side, close to this point referred to as McBurney's point, rather on the left side, which is the correct surgical procedure, according to Dr. Richard Taylor. Now, there have been claims, and I haven't put this on the screen, I haven't put the claim on the screen. I'm not going to mention who made this claim. I don't want to personalise this issue, and I have no idea to... I personally hate Twitter. I've made that clear previously, I'll make it clear again. You just don't get moderate... When I say you don't get, you very rarely get moderate, sensible, thoughtful commentary on things on Twitter. It's just not the way to get a Twitter following, and the platform doesn't lend itself to this kind of discussion. So I don't want to be critical of anyone else, and I don't want to slag anyone else off or say anything rude or even critical about another person. I appreciate on this channel I've been critical of probably some consultants from the Council of Chester, less so than the other two candidates of criticism, Dr. Evans and Cheshire Police. I think I accept that I have been critical of them, and I don't enjoy being personally critical of them, but that is very much predicated on the facts. I suppose you could, a third person would be David Wilson, criminologist. I try not to be personal. I try not to engage in personal attacks. I think that any criticism I've made of those three individuals, whether it's the police, obviously more than one individual in the police, or Dr. Evans, or Taylor, or Wilson, sorry, not Taylor, I don't consider those to be personal attacks. I consider those to be evidentially based. But I don't want to criticise anyone else or make this into a slanging match or anything like that. It's just not of any interest to me. So I just simply want to look at the facts related to the needle insertion. Before we go any further, I just want to take a quick moment. Don't usually do this at this point in any video, but if you're enjoying it so far, please give the video a like. And if you're not already subscribed, then please do subscribe to the channel. It really helps with the visibility of the video, as this commenter on the screen pointed out. If we could get to 500 likes or maybe even 1,000 likes for this video, that would be massive. So thanks very much for your help in achieving this goal. So in this video, we're going to look at several academic studies and other sources as well. The first of these is here. This is related to Dubai. Many of the studies we're going to look at are British, but This is a global issue. This is done all over the world. So there have been numerous studies in various countries. The process we're referring to here is called paracentesis. This is the procedure by which fluid is removed from the peritoneal cavity. So we see in the panel opinion here that baby 15 or child O collapsed because the subcapsular haematoma ruptured, causing acute major hemorrhage into the peritoneal cavity. So in this paper, or in this document source from Dubai, we see here that the needle entry site should be through the left lower quadrant abdominal wall. So we're going to keep emphasizing that as the video continues. And this particular document references McBurney's point, and you'll see this being referenced again throughout this video as a point to avoid, and that it should be, the insertion should be lateral to McBurney's point, precisely so you avoid McBurney's point. As it's stated here, in practice, the left McBurney's localization requires dullness to percussion, the absence of the spleen, and the absence of surgical scars. It's noted here, McBurney's point is 1/3 the distance from the left anterior superior iliac spine to the umbilicus. You'll see all of these things referenced. These may seem incomprehensible, unfathomable aspects of the anatomy, but it will become more clear as we continue, as this keeps being reiterated. But essentially what this document is saying is that the needle should be inserted on the left-hand side of the abdomen, the lower left quadrant abdominal wall. And we're going to go over that continually, repeatedly, and we're going to see the reasons why this is advocated. So this is another study. So this dates back to 1986, just showing this research has been around for quite a long time, 30 years before this procedure was done on child O, in fact. So this is Ascites, ultrasound guidance or blind paracentesis by Bard, Lafortune and Breton. The classic site for paracentesis in generalized ascites is in the lower left quadrant of the abdomen at a position equivalent to McBurney's point. So it's exactly the same thing as stated in the previous document, and you're going to see not only that it's made clear that the left lower quadrant is the idealized place to do it, but also that McBurney's point is referenced as something to look for and something that you need to be parallel with or lateral with, but you must not go anywhere near it. It's notable that it's mentioned here, and you see this figure quoted quite regularly, that this procedure has a success rate of 58%. So this is not an easy thing to do. Anything that is going wrong nearly half the time, it's not working nearly half the time, so it needs to be done well. So I would surmise that if you're doing this in a suboptimal way, that's not very good for the outcome of the operation. And so perhaps it's not that surprising that child O suffered serious problems and indeed didn't survive. So next study we're going to look at is Diagnostic and Therapeutic Abdominal Paracentesis, written by John Harvey, Raleigh Prentice and Jacob George, and published in 2022. This document notes that if ultrasound is not available, then a skin entry site 1/3 of the way along a line drawn from the anterior iliac spine to the umbilicus in the left iliac fossa is an easily identifiable surface landmark, contralateral to McBurney's point. So we're going to see these things repeated. So ultrasound not being available, that's significant, and we'll return to that later in the video. We're going to see this iliac spine and the umbilicus in the left iliac fossa being repeated. We're going to see this left quadrant being repeated. We're going to see this expression contralateral to McBurney's point being repeated. And then actually this document also goes on to give an explanation that we're also going to see repeated, which is that the anterior abdominal wall is thinnest here. It is lateral to the inferior epigastric artery and away from the mobile caisson. So this is another indication that the left quadrant should be used for this procedure. I just put up the word contralateral here, It's not something, it's pretty clear, obvious what it means, I think, but I just wanted to be clear that this relates to or denotes the side of the body opposite to that on which a particular structure or condition occurs. Essentially just means the opposite. So if you say McBurney's point is on the right of the body, which it is, then the contralateral point is obviously the left-hand side. It's the opposite position, essentially. So the next one we're going to look at is revisiting anatomical landmarks for paracentesis by Xiao, Robson and Balipo. And they note, we propose several alterations to the author's landmarks for paracentesis. We advocate the use of McBurney's point as a rough surface landmark, guided by abdominal percussion with the patient in supine position. This is located 1/3 of the distance between the right acis and the umbilicus. So that's just an abbreviation of ACIS is an abbreviation of something that we've seen previously, and is traditionally used to localize appendicitis. The contralateral left McBurney's point is favoured as the abdominal wall here is thinner. So already I'm sure that this is something that you're familiar with because we've heard this in previous documents. So the next one we're going to look at is Paracentesis, Do I Really Need the Ultrasound by Dr. Nick Rutherford. So Dr. Nick Rutherford here mentions blind paracentesis, which is again very significant. So we've already heard ultrasound being referenced, and we're going to go on to discuss this later in the video. So blind paracentesis is most often performed in the left lower quadrant at a location that mirrors McBurney's point after a clinical assessment for ascites. I hope I'm pronouncing ascites correctly. It could be ascites. I don't know how to pronounce that. I possibly should have looked it up before I started. But there's so many things I don't know how to pronounce. It would take forever. But the point is that, again, this document is saying it should be performed in the left lower quadrant. It should be in a location that mirrors McBurney's point, so in the opposing part of the body. And this, again, is quoting this 58% chance of success. It notes as well that a blind paracentesis is often unsuccessful for small volumes of fluid. So when you're performing this blind without imaging, we'll discuss this later in the video again, but the success rate is lower, it's more difficult to do. It notes here that the rate drops to 44% when 300 millilitres of fluid are present. So next one is choosing the location for non-image guided abdominal paracentesis, published in November 2005 and authored by Sakai, Shear and Mendler. Now I believe this is a particularly important document in the development of this procedure because it's often cited in many of the studies that I've read as I've researched this topic. So these authors know that the optimal location for paracentesis has not been studied scientifically, so this is kind of a pioneering study. And they state here, ultrasound measurements of abdominal wall thickness and depth of ascites were recorded in two locations, the infraumbilical midline and the left lower quadrant, in 52 patients with cirrhosis and ascites admitted to a single inpatient liver unit. The abdominal wall was significantly thinner and the depth of ascites greater in the LLQ, the lower left quadrant, as compared with the infraumbilical midline position. In the left lateral oblique position, the difference in the depth of ascites was more pronounced when comparing the left lower quadrant with the infraumbilical midline. And then there's some figures, 4.5 versus 2.78 centimetres. The left lower quadrant is preferable to the midline infraumbilical location for performing paracentesis. So again, that is very, very clear. It can be done in the midline, but it should definitely be done in the left lower quadrant, and there are very clear reasons for this. We're seeing again this emphasis that the abdominal wall is significantly thinner, and that makes it easier to perform the procedure. So there's another post here in Human Anatomy and Embryology, in which they note that paracentesis is a procedure in which a needle is inserted 1 to 2 inches through the abdominal wall into the peritoneal cavity to obtain sample or drain fluid while the patient's body is elevated at a 45-degree angle. The puncture site is midline at approximately 2 centimeters below the umbilicus or lateral to McBurney's point, avoiding the inferior epigastric vessels. So again, exactly the same emphasis that we've seen previously. Now moving on to the panel verdict. At one stage during their verdict on child O, they note that the blind abdominal insertion of a needle during resuscitation may have penetrated the right lobe of the liver, causing further injury noted by the pathologist as parenchymal haematoma and laceration. So what is important about this is the reference to this being a blind abdominal insertion. So this was done without the kind of medical aids and imaging that are often available. In this case, they weren't used, which makes a big difference to the process. And as we've seen in previous references already, if you don't have imaging, if you don't have ultrasound, then it becomes more important to use the left lower quadrant. We know for a fact, it's not denied at all, that the left lower quadrant was not used because the needle was inserted in the right side of the body, as we'll see in a document that I'll present later in the video. Now, in another article here by Dr. Nick Rutherford, Paracentesis Procedure Steps in Emergency Situations, Dr. Rutherford references the fact that if a surgeon is taking a left lower quadrant approach, which is preferred in the absence of imaging. So we know there's no imaging. The panel are referencing the fact that they didn't have imaging. We've seen in previous documents references to ultrasound and references to imaging, and that in these circumstances taking a left lower quadrant approach becomes more important. It's best practice anyway, but in these circumstances you should be taking a left lower quadrant approach to this procedure. Just wanted to mention that I've had a procedure with imaging. So it's often done where so this is laparoscopic fundoplication. So this was why I believe it was child G had gastroesophageal reflux, which was something that I actually recognised because I had this myself, and that's why I had this procedure. I've been told that it's not done very often now, which is a shame for certain people because it did solve the problem for me, albeit my digestive system is still terrible. But anyway, I had my stomach opened up while I was asleep, and they insert a camera into your stomachs and then stable you back up, basically, and then there's a 6-week recovery. So that was an operation done with imaging. But for this procedure, this paracentesis procedure, imaging was not available for the cancer Chester. So we're going to look at this study on paracentesis by Aponte, Katter, Kurapati and O'Rourke. And this study notes that paracentesis can be performed in a lateral, decubitus or supine position with or without imaging guidance. When performing a paracentesis without imaging guidance, it is recommended to use the left lower quadrant of the abdominal wall as the entry point for the needle. We're also going to look here at risk of complications after abdominal paracentesis in cirrhotic patients, a prospective study. This is authored by De Gottardi, Thevenot, Spa and Torres. So very international, and Giostra. So let me not forget the other two, Giostra and Hadenge, I think that might be. So a very international panel of doctors published this. It looks as if there may have been other authors as well, but that's 6 of them anyway. And again, they just outline the fact that the preferred site for needle insertion was in the left lower quadrant. I believe this is outlining some actual procedures that have taken place. And we're just going to look at transcatheter coil embolization of the inferior epigastric artery in a huge abdominal wall haematoma caused by paracentesis in a patient with liver cirrhosis. Published by authored by Park, Lee, Kim, and Lee. That's what you need from authors' names. So I'm going to go over the whole of this because they gave a lot of detail in their summary. Naturally, between the peritoneal membranes, there is a thin blade of fluid which allows the sliding of abdominal viscerae, but the quantity is not enough for allowing collection by puncturing. In pathological situations, fluid may accumulate in the peritoneal cavity, which may be extracted through puncture. The choice of the peritoneal puncture site should take into account the necessity to avoid important blood vessels and the presence of certain mobile viscera, which could slip from the needle subjacently to the puncture site. In patients with cirrhosis and parietal collateral circulation, avoid visible dilated veins. The posterior side of the straight abdominal muscle contains the lower epigastric artery, which is anastomosed with the internal mammary artery. The cecum located on the right side of the abdomen is a fixed segment of the colon, where the sigmoid colon located on the left side is a mobile segment. Taking into account all these facts, the ideal spot for the puncture is on the left side of the abdomen on the spino-umbilical line at the intersection of the lateral third with the two mid-thirds of this line, or the midline 3 to 4 centimeters under the umbilicus. So this particular document references the midline, but it makes clear that the right-hand side is to be avoided, and the ideal puncture spot is on the left-hand side of the abdomen. So before I go any further, there are just a few things I want to say in mitigation. So there are documents out there which state that you can use the left lower quadrant or the right lower quadrant, but what the poster who has made this initial comment may not possibly understand is this absence of imaging issue. So it's very clear that if you're not using ultrasound, that you should use the left lower quadrant, and generally this should be considered best practice anyway, because there's a very compelling reason why you don't use the right lower quadrant. I don't really understand why there are any documents out there saying that you can use the right lower quadrant, given that there's this pioneering study that explains exactly why you should use the left lower quadrant, why it's preferable, for what is a difficult procedure as well. So it's possible that the person posting this doesn't understand that this was a blind, what is described as a blind procedure. So there's no imaging. So they're just doing it by sight, essentially, which makes it a lot more dangerous and a lot more likely to go wrong. There's a reason why we have ultrasound. There's a reason why things are put up on a screen and why imaging is used. It's because it makes the process a hell of a lot easier and a hell of a lot more precise. And with a situation such as this, firstly, they've entered with the needle in the wrong lower quadrant, and then, as you've seen in all of these studies, there's this reference to being contralateral, or on the opposite side to the McBurney's point, and if you get close to McBurney's point, it's dangerous. So, and it's not merely the fact that this can go wrong, and that this has seemingly gone wrong in the case of child O. It's also the fact that it can still go wrong if you use the left lower quadrant. It fails in 42% of procedures, according to these figures, but you're giving yourself a better chance of completing the operation, and you're taking this particular problem out of the equation completely. And that's why you're seeing this contralateral reference saying you need to be contralateral to the McBurney's point. It's emphasised in several documents. And all of these things may not be understood by the person that posted this claim that it doesn't make any difference whether you do it on the right side or the left side, when actually that's just not sustainable as a view. But they simply may not understand that when you're doing this operation blind, and they were doing the operation blind, that you should use the left lower quadrant. You should use the left lower quadrant anyway, but under these circumstances you should definitely use it. And the difference is that this has been advocated by a panel that are so decorated in the field of neonatology that it's untrue, whereas the person that's made this assertion has never even seen a scalpel before, and he's not a medic, and he's certainly not a surgeon. So that's the difference. And of course, she simply might not be aware about the information that's on the screen now, about the left lower quadrant and about the imaging. So I'm just going to go over some of the details of the panel as briefly as I can. Firstly, Dr. Xu Li is Professor Emeritus, University of Toronto, Honorary Physician at Mount Sinai Hospital, and President of the Canadian Neonatal Foundation. Eric Eichenwald is Professor of Pediatrics, Perelman School of Medicine at University of Pennsylvania, Chief of the Division of Neonatology at Children's Hospital of Philadelphia, holder of the Thomas Frederick McNair Scott Endowed Chair. Helmut Hummler is the Senior Medical Director at European Foundation for Care of Newborn Infants in Germany. Tetsuya Isayama is the Head of a Division of Neonatology at the National Centre for Child Health and Development in Tokyo, Japan, and the Director of the Asian Neonatal Network. Joanne Langley is the Head of Division of Pediatric Infectious Diseases at Dalhousie University in Canada, Professor of Department of Pediatrics and Community Health and Epidemiology at Faculty of Medicine, Dalhousie University, holder of the Canadian Institutes of Health Research, GlaxoSmithKline Chair in Pediatric Vaccinology at Dalhousie University, Active Staff Pediatric Infectious Diseases, IWK Health Centre. Nina Money is Professor of Neonatal Medicine and Vice Dean International at Imperial College London, Honorary Consultant, Chelsea and Westminster NHS Foundation Trust, President of the European Association of Perinatal Medicine. I should say as well that she's held essentially all the most credentialed neonatal positions in Britain. Mikael Norman's Professor and Senior Physician, Department of Clinical Science, Intervention and Technology, Karolinska Institute in Sweden, Chairman of the Swedish Neonatal Quality Register, founder of International Society of Evidence-Based Neonatology. Bruno Piedberf is Professor of Titulaire en Pédiatrie, Université Laval, Canada, Coordinateur des Services Cliniques de Ruisse de l'Université Laval. My French is not very good. Prakash Kumar Shah is Professor of Pediatrics, University of Toronto, Canada, Head Department of Pediatrics and Maternal Infant Care Research, Mount Sinai Hospital, Senior Clinician Scientist, Luna Felt Tannenbaum Research Institute, Director International Network for Evaluation of Outcomes for Neonates, Director of the Canadian Preterm Birth Network, Scientific Advisor and Past Director for the Canadian Neonatal Network. Nalini Singhal is the Professor Emeritus, University of Calgary, Canada, co-editor of the World Organization /AAP Helping Babies Survive programs. Eric Skarsgård is the Professor of Division of Pediatric Surgery, University of British Columbia, Canada, and Director of the Canadian Pediatric Surgery Network. And Anne Stark is the Professor in Residence of Pediatrics at Harvard Medical School and Director of Faculty Development, Department of Neonatology, Beth Israel Deaconess Medical Center. So this is an enormously credentialed group of people that know the subject area inside out. This is not just a group of doctors. As you've seen from those descriptions, these are people that are head of credentialed bodies time and time again. And now as well, it's nearly double that number. So we've just been over 13 people. There's a further, this is 13 of the 14 in the initial panel, and there's now a further 12 experts. So when these people make an assertion about something, they're not making it for no reason. They're making that assertion because they are among the most credentialed experts in the world, and they know their subject area like no one else on the planet. So that's why when they state that a needle needs to be inserted into lower left quadrant, they're doing that for a reason. And unfortunately, someone working in a hospital in Chester and someone commenting on the internet who's not even a surgeon, in fact, not even a doctor, not even a medical doctor, let alone a surgeon, is just not going to be correct. There is a reason that they're saying this, is because they know, not only do they know the subject matter inside out, they know the literature inside out. They know everything about this topic, because you don't get to be in these positions unless you've done a lot of surgery. It's not like they've been watching on the sidelines and just thinking, oh, I'll read about this, or I'll read about that, or I'll watch what's going on. They've done these kind of things many, many times. Otherwise, they wouldn't be in the position they are now. It's as simple as that. And to actually question their word when you're not a doctor yourself is staggering, frankly. And the only way you can do it is just to Google things. And that's just not good enough. I know for myself that is what I rely on, but also I've interviewed, which is a big help, of course. I've interviewed many healthcare professionals. I've interviewed over 50 people, so that helps a lot. But certainly sometimes I have to look up things on Google, and I have to be very careful about what I'm saying, because I know I can make mistakes very easily. I must say that I have had doctors fact check a lot of the stuff that is included on this channel, so I know it's been backed up by physicians, it's been backed up by medics. So that's why I feel confident about asserting it. For this particular video, I've not sought any feedback or any fact-checking from doctors because I haven't had time. So this is just my own work and my own research. But I was very confident about looking up this topic because you have all of these leading experts saying that this needle insertion must occur in the left lower quadrant. So I was pretty sure that they would be correct. Because you have to understand as well, it's not merely the fact that these people are experts, that's undeniable, but they're putting their reputations on the line for nothing, for something that doesn't benefit them in the slightest. Obviously, it's been well documented that they're not being remunerated, so they're literally gaining nothing from this. That you can't. People have tried to claim, they're gaining some sort of publicity, or they're already the best people in the world. They're already top of the top organisations in their countries. They have nothing to gain. They will be moderately wealthy people, and not perhaps compared to, I don't know, like bankers, for example, or people at the top of finance. But understandably, these people are paid very good salaries, and rightly so, because they take on an enormous amount of responsibility. They're dealing with life or death situations every day. It takes a huge amount of training, it takes a huge amount of expertise, and a huge amount of knowledge. So they deserve to be paid a good salary. The one thing that I would like to see is more access to the medical profession from people from, working class, blue collar, lower middle class backgrounds, because it is very difficult. But that's not the fault of these people. These people, I don't know their background, but they've worked very hard, they've studied very hard. There's just no other way to get into these positions. So to say that they need publicity or they need attention is just nonsense. It's absolute abject nonsense. And that the sole reason they're doing this is because they've agreed, because they know this guy, Dr. Shu Lee, who is president of the Canadian Neonatal Foundation. Now, I know for a fact, because I spoke to a doctor who's an award-winning doctor in Canada, whose wife is a neonatologist, that this guy is extremely well known in Canada. So he's not going to be putting his reputation on the line for no reason. And the reason all these other people have come into the case is because this guy, Dr. Shu Lee, will have an enormous address book full of leading neonatologists, and that's why he's able to call them in. And he said, look, will you just look at this case for me? I believe this is a miscarriage of justice. Now, all of these people go into this field for one reason and one reason only: to help people that are vulnerable, to help people that are in need, to help babies, to help infants, and to help their parents, and to deliver a service that makes society a better place, essentially. And by the way, I'm sure that's part of the reason Dr. Stephen Breary became a doctor. And I wouldn't doubt that for 1 second. But these people are not going to put their reputation on the line for no reason. The reason they're doing it is because they know that something very egregiously wrong has occurred here. And that's why they've spoken out, and that's why they've put the medical data into this case that is now available to the Criminal Cases Review Commission and will shortly be available to the Court of Appeal, is because they know that what happened in court was wrong. And these are the most qualified people in the world to assess that. So when they say the needle should be inserted into the left lower quadrant, I'm certainly not going to assume that they're wrong, and I'm certainly not going to question what they're saying without very good reason. If anything, I will just assume that they're correct, because they're the top people in the world that have been working in these fields for decades, that are heads of these bodies, that have been through 10 years of training. You have to do 10 years of training to qualify, just to be a neonatologist, never mind being one of the top neonatologists in the world. So the idea that someone with no medical qualifications is going to pick apart what they're saying is ridiculous. So I'm obviously very careful not to do that, and I'm very careful when I make any claims myself. But obviously I began with the assumption it's very, very likely that these people are correct. Now, I've seen claims, as I've stated, that you can just insert a needle on the right-hand side of the body or on the left-hand side of the body, and it doesn't make any difference. And obviously, in the report for Child O, it is asserted, we don't know which two of these neonatologists compiled that report, but we know that two extremely qualified and credentialed people did compile a report for Child O, and they cited specifically the fact that the needle should be inserted in the left lower quadrant. Now, I assume immediately that if they say that, that it will be very easy to find documentation to support that, and it was very easy. The research for this video did not take an enormous amount of time. It took about 2 minutes. And if you don't think that what I'm saying is correct, then look it up for yourself. But as I've mentioned previously, there are documents out there that say you can insert the needle on the left lower quadrant or the right lower quadrant, but particularly, firstly, it's best practice to do it on the left lower quadrant. That's undeniable. But it's very important to note that when this is done blind without imaging, that was the case in the procedure conducted at the Countess of Chester, it should essentially always be done in the left lower quadrant. There is no reason anyway for not using the left lower quadrant for the reasons that I've outlined in this video. But when you're doing it blind, you must do it in the left lower quadrant. And all of these neonatologists that know this topic inside out are aware of this, and that's why it's in the report. Now, if I was trying to critique this topic blind myself, if I didn't know any of the information, if you just said to me about paracentesis, where do you insert the needle? I haven't got a clue. Why would I? I don't even have a medical degree, let alone if I specialise in neonatology. There's absolutely no way for me to know where the needle is inserted. So off the top of my head, I wouldn't have a clue. Neither would the person that's criticised the work of these absolute world experts in their field. There's no way that I could have walked you through this. I could have tried to research it, but I would have been in great danger of making errors because it's an extremely complicated area. It's a very specific area, and I don't know the first thing about it. So what has probably occurred when these documents have been presented is that someone has essentially Googled a few things and tried to disprove the idea that the needle shouldn't be inserted on the left lower quadrant. But if you actually do the research properly, it's very easy to prove that it should be inserted on the left side. And if you don't believe me, look it up for yourself. And before we go on to the next section of this video, I just want to mention as well that everything I've just said also applies to Dr. Stephen Breary, and indeed all of the people that worked at the Countess of Chester. But let's focus on Dr. Stephen Breary, who conducted this particular procedure. Dr. Stephen Breary is a jobbing doctor in a not particularly highly regarded hospital in Chester. And when I say it's not particularly highly regarded, that was before the Lucy Letby case. I mean, I've spoken to people from the region, and this hospital is just not considered to be great. And of course, for example, Michelle Warden has come out and given indication of many problems with this hospital, and she obviously worked there for many years. So this is not, there is no real comparison between Dr. Stephen Breary and the panel. That also applies to Dr. Dowie Evans, who's the lead prosecution witness. Dr. Dowie Evans hasn't worked in a hospital for 20 years and was a paediatrician in a hospital in Swansea. It's just no comparison with these people. Even at the height of his career, when he was actually working in Swansea, there's no comparison, but he's been out the loop for now nearly 20 years by now, even 15 years when he was in the court case. And of course, he's not even a neonatologist. There is just no comparison with this panel whatsoever. Moving on to the next point, another claim that I've seen made online by the same person is that the needle insertion that has since been cited by the panel and cited by Dr. Richard Taylor, the evidence of this was available to the coroner at the time that the coroner filed their reports. So in order to support this assertion, the document INQ 0008605, page 7 of a letter from Dr. V regarding her involvement in the care of child O, dated the 3rd of November 2016, has been cited. So I particularly want you to look at the date 3rd of November 2016 because that will become important as we continue. So this document notes that child O's abdomen was noted to be significantly distended. Dr. Breary inserted an intravenous cannula line to its McBurney's point, the right side of the lower abdomen, to try and decompress the abdomen. A small amount of blood was obtained, which was sent for blood culture. Now, we've just seen all of those documents saying that you don't do this when you're doing a blind procedure. So there's no doubt that this was done incorrectly, first of all. Secondly, there's also no doubt that this letter is dated the 3rd of November 2016, as is reiterated here. Now, Childo, this is from a Guardian article. They very much changed the position. This was shortly after the court case. So it does say murder of Childo, which I don't believe that Childo was murdered. But the date of this incident is what's important, which is the 23rd of June 2016. So this is some 4 months and about another week and another few days, approximately 18 weeks before this letter emerges, that Childo passes away. So the coroner doesn't wait until November to gather the information. The coroner acts immediately after the death of a child. So that immediately rules out the idea that this was in the coroner's report. The fact actually that people are citing this document and seriously posting it online and saying, oh look, it was known about the time. Perhaps there are three possibilities. Either they're stupid, that's a possibility, or they just hope that people won't look up the dates somehow, and that they can just say things and that people will just believe them, even though they're completely unfounded. I suppose if you wanted to be phenomenally generous, you could say that they believed that this was the 11th of March and it's written in American, the way that American dates are written, rather than the 3rd of November, which it actually is, and that they were mistaken, which would still be unbelievably stupid and wouldn't rule out the first thing, but I suppose you could claim that. I don't know why anyone would conceivably claim that a document from the 3rd of November 2016 was somehow available for coroners for an infant that died approximately 18 weeks earlier. Frankly, it's utterly ridiculous. And what you'll also see is that not only was this not available to the coroner, it wasn't available to the pathologist. So this is the first document from the Thirlwell inquiry in which Dr. Jane Horden has a discussion with Ian Harvey from the Council of Chester. And this was sent on the 8th of September 2016. So it's still predating this document by 2 months. And we see her here corresponding with Ian Harvey on the 29th of October 2016, reflecting on problems with the process that is now completed, which is still predating this document that emerges on the 3rd of November 2016. So this is the post-mortem review report that references a ruptured subcapsular haematoma of the liver and hemorrhaging in the peritoneal space due to rupture of the subcapsular haematoma. So we see this is actually the important aspect of this whole issue of the collapse of the infant, of the sad demise of Child O. And this is what is primarily cited by the panel. The needle is really a secondary issue, but it is of some importance, but it's not really essentially the cause of death, rather. It's just significant in some of the bleeding and hemorrhaging that was observed. The collapse occurred because the subcapsular haematoma ruptured, causing acute major hemorrhage into the peritoneal cavity, sufficient to cause a near halving of the hemoglobin level. You see, the panel also note that high pressure ventilation decreased venous return to the heart and contributed to liver congestion. So in the latest Private Eye today, that's written by Dr. Philip Hammond, he notes that this information about ventilation and this information about the needle was not passed on to either the coroner or the pathologist, and that the likely explanation for this is simply that people on the unit didn't have the knowledge base required to realise that it was significant, which is why they got it wrong in the first place. So in the conclusion, we see that Child O died from a subcapsular liver haematoma caused by traumatic delivery, resulting in hemorrhage into the peritoneal cavity and profound shock. This was not recognised ante-mortem. And then we see another pathology report here in which it's noted there's a ruptured subcapsular haematoma of the liver, and that this was this led to hemorrhaging in the peritoneal space that was critical in the passing away of this infant. Now, how this has been overturned, because in the actual court proceedings related to Child O, this was barely mentioned. It was just brushed over in a matter of seconds almost, and it received almost no reference whatsoever, when this was the pathology conclusion and is now the conclusion of this panel of neonatal experts. Yet in court, we saw Dr. Evans stating that an air embolism was really critical in this infant. And we can see it here in the Court of Appeal document, in the Court of Appeal judgment for Child O, that the mechanism of death was injury to the liver / air embolus. So Dr. Evans seriously suggests that the insertion of air was significant in the death of this infant, which is almost surreal given that the clinical signs of this infant just bear no resemblance to anything related to air embolism, while there are clearly numerous other really important things going on. How you can have a supposed scientific discussion in court in which there's a long debate and a lot of evidence presented in relation to air embolism, but we barely hear about the fact that there's been a subcapsular haematoma that ruptured, causing massive hemorrhaging. That's just brushed over in a matter of seconds so that Dr. Evans can talk about, oh yeah, there's these purple rashes, even though we know in other cases where there are rashes, the rashes are a different colour. But it just gets passed on, just like the it's always Lucy theory, it's always Lucy on duty, so we can just pass that on from one case to the next. The rashes also get passed on from one case to the next, even though the rashes aren't consistent. They're not only they're not consistent with air embolism itself, they're not even consistent from one infant to another. So the case of Child O was an extraordinary one in the court case, and how it's even in the court case, I have absolutely no idea. But anyway, the point is that this second claim that I've seen made by the same person, is probably made by other people who wish to buttress the guilty verdict, that the coroner had access to the needle information, is just plainly incorrect. So before we summarise this video, I just want to emphasise again that I only used a small number of sources for this video, because otherwise I would have been repeating the same thing over and over and over again. But I have many other sources available, literally dozens, that are all saying exactly the same thing. So I'll post some of those on Twitter so that you can see them. But if you don't think that what I'm saying is correct, then just look it up yourself, because it's not difficult to find this information being cited. So in summary, it's been established that an important medical procedure in the case of Child O was conducted incorrectly. This is thoroughly documented and undeniable. The court and jury heard nothing about this. A subcapsular haematoma is actually more significant in this case, but this was brushed over in court. The prosecution relies on air embolism as significant in the case of Child O, which is utterly farcical, as it is in no way consistent with anything observable in this infant. So that's the end of this video. What I wanted to add was that this is just one small issue in the case of Child O, and I will cover this along with probably all of the children in the case in depth at some point. It's just literally a case of working through one topic after another. There are so many to work through. I haven't even not even begun to scratch the surface of this case yet, that there's so much more to look at. But it's just, I can do a video every 2 days that's in the kind of ballpark length that I've been doing, and that seems to work out okay, and people don't seem to think that's too much, and it's doable for me, and that's the maximum that I can do. I can't do this every day, it's just too much, and I can't ask people to watch an hour every day. So we can't progress as quickly through this case and as quickly through the many problems as I would like to, but this is the fastest that I can do it while doing each of these videos as thoroughly as I can. So thank you again for all the support, and I'll look forward to reading your comments. If you have any queries, questions, observations or corrections, please do let me know.